right, thanks so much, Josh. And I just wanted to say a few words just about AMCSI in general. I just feel so lucky and blessed to just, even though I'm not a parent or an individual with orthogryposis, this support group is just something really special. I think just one of the most unique and special organizations I've ever been part of. So I appreciate you all being here, and I appreciate AMCSI for allowing me to speak today. All right, so we're going to talk about feet today. But first, I can't really talk about feet just in isolation. I have to see the whole individual. So I'm going to touch a little bit about how we do feet in Greenville. Some of it will be echoing what Jackie and Trish talked about a couple hours ago. But we'll breeze through that, and then we'll go into, and then we'll dive all into feet. Maybe a little bit too much information, but we'll try to keep it interesting. And please make this interactive too. If you have questions, like please raise your hand and or get my attention. We can make this more interactive, less lecture style, but whatever you guys want. So, all right, let's jump in. So let's talk a little bit about Shriners, just for folks who are not near a Shriner, who maybe haven't heard of one. So the healthcare system was established 100 years ago. We're all over North America. Three-part mission: patient care, research, and educating the next generation of medical providers. So we take care of kids regardless of their ability to pay. And in general, we keep kids birth to age 18. So this is a little bit of what our hospital in Greenville looks like. We have an outpatient clinic, an OR, a prosthetics and orthotics lab for your bracing, therapy gym, and then something that makes our hospital unique as well as our motion analysis center, which allows us to study away a child or ambulate. So our AMC mission is to partner with families to promote mobility and advance each child to their highest level of functional freedom. And we do this by considering the whole child. Each child's physical presentation is unique, but layer that into their family dynamic. And we can't just look at just one body segment. We have to consider the whole child, the whole situation. We need to focus on, can we do something efficiently, but how we do it is of secondary importance. So we very much embrace the bookend strategy. My family hears me all the time. It's like, let's get this child standing and walking. Let's also get them a chair so they can go from A to B efficiently. Sitting is good and wheelchairs is good. They each plan is individualized for the child. We do have kind of a baseline goal of a standing transfer. So I think if you can do an independent stand transfer, that just opens up so much with regards to independence. So you hear me talk about this a lot too. It's a team approach with a three-legged stool with orthopedic surgery, PT and OT, and orthotics. And if one of those is not going well, then the stool topples over. So, but at the center of that is the family. And so we very much embrace a family-centered, multidisciplinary approach. All right, so let's transition now to feet. Really what you're going to notice is that it's not a one-size-fits-all approach. But our feet are connections, our feet are body connections to the earth. They're what literally grounds us. So it's so important. Our goals of treating the foot in a patient with orthogryposis is to have a pentagrade foot, which means that the foot can get flat on the ground, that it can fit into a brace or a shoe, and that is as pain-free as possible. And we want to do that with a reasonable amount of intervention. So I think one of the picture on the left is from like an ancient Egyptian painting, but you can see potentially this person has either a club foot or maybe orthogryposis just upon them, just based on the position of that foot. That's not a really good foot to walk on, especially if you're in ancient Egypt. It's not a really good foot to walk on today either. So let me have a brief disclaimer. I'm going to discuss like most known strategies. I probably won't discuss all strategies, and I'll discuss a few strategies that maybe I don't personally put a lot of time or weight in, but I think it's fair to you all just to kind of know what all the tools in the toolbox are. Some of you, and this statistic shows maybe 50% of you have an ultrasound that's like this, that shows some club feet while the baby is still in utero. And so we'll start off with the babies, and we're going to progress through each age and stage as far as like the treatment options that are available. So we love babies in preschool. There's something just extra special and cute, we feel, about a baby with arthritis. And I think for me, it's just when I do have an opportunity to meet a baby who's just really young, there's just so much potential. And then even just orthopedically speaking, there's just so much opportunity to improve range of motion with more conservative treatments and without necessarily offering surgery. So they may look like they're at their worst, but they're really the most responsive to stretching and casting and conservative treatment. So let's talk about the different flavors of feet. The kind of two main flavors are either a club foot or a congenital vertical pivot. The club feet far and away are the most common, and there's a subvariant described by Dr. P. about the equine pivot split, which we'll touch on here in just a minute. And then the other being congenital vertical pivot, which is about 20%, happens about 20% of the time. That's a picture of the equine pivot split. And then the congenital vertical pivot. And so let's break it down. This is just a good anatomy lesson for you guys. And I really do think that knowledge is power. So the more you understand like what the components are, the more you can advocate for yourself or for your child. So CAVIS is, we remember this by the acronym CAVE. This is even how we teach our residents. So CAVIS means high arch. Adductus means, oh no, the picture didn't show up. Means that it's got a kidney bean shaped foot. Varus means that the heel rolls in, and then equine is indicating the tight heel cord. And so without intervention can be very disabling. And we used to recommend a big surgical treatment, like right off the bat, even if you're just an idiopathic club. So we say, nice to meet you, we'll see you when you're 11 months old, and we'll do a big open release. So we don't agree with that anymore. There's a new standard of care, the Ponseti method, which was initially described for idiopathic club feet. So children not with arthritis, but where they're only different with the club foot. But we've since adopted that for our AMC population as the initial intervention, especially when we need it. So the technique is to do zero casting once to twice per week, and to conclude that with a percutaneous heel personality. Depending on how active the child is and how old the child is, we can either do that down in the clinic or in the operating room, just depending on the age of the child. And then we do casting to obtain correction, and so again, once or twice per week, and then followed by the heel personality. And then part two is to maintain correction. Let's take a quick detour to the equine cavus deformity. So the treatment principles are very similar, but they don't have that varus component that we're talking about, that V of the cave. And so in order to treat children with the equine cavus deformity, we use what's called the four-finger technique, where we'll stretch out that cavus, that high arch, and then conclude treatment with the heel personality. So part one, obtaining correction, is casting and surrounding. Part two is maintaining correction. And so if all you have is just idiopathic club feet, you'll go into that image on the right, this is the bar. But our children with arthritis tend to not be the best kickers, which is what keeps those children with idiopathic club feet in those braces. And so we tend to prescribe more custom AFOs, even in the itty bitties. Sometimes we'll layer that with the boosted bar on top to get that abduction moment. But really, we just have to, the AMCers don't really like to play by the rules, but when it comes to the bracing, we just have to get creative and do whatever it is they need. So what are the outcomes? So throughout the talk, I'll just pull a couple studies that show you kind of an overview of the outcomes. Basically, 70% initial satisfaction, 94% initial correction, 100% initial correction. So you can say Ponseti works for initial correction. So let's talk about, we all know our nemesis with our varicoses is, man, it looks beautiful in the OR. Well, what happens pretty much later? A little curve, okay? So we're always battling recurrence. That's really our nemesis. We can really expect with the club foot through childhood of bracing. Maybe not a lifelong of bracing, and that was a question asked in the orthotic talk. But really, we can decrease our risk of recurrence by being compliant with our bracing, by advocating for our child, by learning things like the French method, and different stretches. And then when the kids do become more ambulatory, just having those feet on the ground and interacting with the ground helps to decrease their risk of recurrence. So why do kids with arthritis recur so much? Well, let's just detour a little bit, and maybe hopefully this will help to help you to understand it. The bones in children with endometriosis are not really affected. They still have the normal growth plate, but the muscles around the bones are affected, and the muscles tend to be very fibrotic. So most typically developing children, most normal skeletal muscles have a good amount of stretchiness to it. Our kids with arthritis have very tight muscles, and so what happens is they still grow, they're still children, their growth rates are still going, but then those tight muscles don't stretch. So then that's what causes recurrence. So a couple more things to be aware of. Something I just kind of recently, maybe in the last couple of years, as I have been doing more casting, a lot of my babies really don't like it when I cast, and even the older children too. And so if you have a fairly thin foot, you can actually feel along it, and they feel like this little tiny spaghetti noodle structure. Well, that is a superficial perineal nerve, and it gives sensation to the top of your foot. The unfortunate thing is where I need to put my thumb is right where that nerve is. So I do think, babies tend to be, tend not to like the casting process, and especially if they're a little bit older, they may be able to articulate that. But I think it's just something to be aware of and not just say, oh, they're fluffy. Like, I do think they have some pain with it. It's the pain that it's kind of necessary for them to get through. Just be aware that the x-rays are often worse than what what it actually looks like. Sometimes clinics will say, oh, that looks really good, let's get an x-ray. The x-ray doesn't look as good, but just to be aware of, we treat patients, not x-rays, so. Pressure sores, this is a big one, both with casting and with bracing, something that we at times need to navigate through. And then stubborn feet. Sometimes we have a foot that the ponseti method is just not working. So there's a surgeon in Seattle named Vince Mosca who's on the brink of retirement, but he's described what's called the Mosca approach. If we have a foot that's just being very stubborn. And so what this approach has involved a minimally invasive soft tissue release for the recalcitrant club foot. So it's a percutaneous Achilles tendinotomy, mini open plantar fascia, so that's that plantar fasciitis, that band on the bottom of your foot, you release that. Doing little tiny releases of the toe flexors, and then you need to reinitiate casting to get the rest of the correction. So this is just some brief pictures, something not too gory, little tiny incisions. And then you follow that up with casting, and your result is pretty good. And then the last thing, I'm sure this is more for humor, but actually there's some serious about it, that a lot of our kids with AMC have what I call AMC toenail. And I'm sorry, I don't have great answers for that, but we'll try. But they just get that nice slow toenail, or sometimes like it's that round towards toenail, and we have to put our minds together, so what to do about it. Okay, so that's clubfoot. Any questions on infant clubfoot? We're going to go into the school age and adolescent. Good. Okay, all right. Let's do it. So I need you to change your thinking, and now we need to think the opposite. So we're going to talk about congenital vertical talus, which is basically the opposite of clubfoot. So, congenital vertical talus. Let's break that down to what that means. Vertical. So talus is the rocker bone in your ankle. Vertical means it's pointing up and down. What happens is the talus is the bone that connects your ankle to the rest of your foot, and the rest of your foot is sitting dislocated on top of the talus bone. And so that's kind of a picture of what it would look like in an infant. And so the old standard of care, again, similar to ponseti, old standard of care, if you're like, oh, nice to meet you, when your baby's like 1, we're going to do a big operation. And we've learned that there is a potential for a better initial treatment called the Dobbs method, or which is called the reverse ponseti. And it's basically casting in the opposite direction. So whereas the clubfoot is kind of down and under, the CBT foot is up and out when we cast that gradually to bring it down and under, almost to create what is pretty similar to a clubfoot deformity. And then we follow that up with a smaller surgery to make sure that joint is reduced and pin the joint, and then also do a J-foot tenotomy. So it's kind of like a clubfoot, but it's like backward street, if you think about it that way. And then part 3 with that would be bracing. Bracing for these feet tends to be a little bit represervation than with the clubfoot. Once we get the CBT foot looking good and can keep it there for a couple of years, those kids tend to not need bracing as long. So that's maybe one of the silver lining with CPT. So talk about outcomes in general. The reverse content work for your initial correction. So let's talk about the consumer companies that doesn't want to respond. So I do, and sometimes family dynamics too. Sometimes families just can't come for weeks of casting, or there's other things going on. But I do think the over-release is a good surgery. I just like to try to do it in a little bit older child, not in a super young infant. If I have a really young infant, then I'm certainly going to try to reverse something that is first. But I thought I achieved pretty good results with the comprehensive open release if need be. This is the child that I did her surgery close to 2 years of age. The X-ray on the bottom is 1 year follow-up, and she's pretty good at what we create segmental alignment, where we break down the foot by different segments in her head, and she's maintained very well. So, what if the comprehensive open release we can't get it? Sometimes we can take the bone that's sitting on top of the talus, called the navicular, and take that bone out. The bone beyond that, called the cuneiform, to make a nice cup for the talus to sit in. And so I ended up having to do this on this young man, and really his X-ray, the casual look, he would really notice that the bone is missing, and he had really good functional outcome too. And then lastly, preserve the ship for kids that are, or for children who are done growing. This is a giveaway from India that actually has some sort of open release done in India, so she has a lot of scar tissue. I have to put her in some custom shoes that are just like custom molded to her feet, and she's very happy that way. But if or when she comes back to me, I really think the only strategy for her would be to try to use some of the joints in her foot to get a better foot shape. So that's kind of a picture of what her foot looks like. So this wraps up infant feet for the first 3 or 4 months. And thank you to the Russells for this nice compilation of pictures. But for the first 3 or 4 months, it's truly the golden window to improve range of motion and really redirect the trajectory of the child's life. And so the summary with infant feet is that we're going to try casting first, hopefully with a minimally invasive surgery, and then maybe bracing, which is all of our pie in the sky ideals. That's what we would love to do with all children. So just a real quick, just a vignette of one of our patients, Asher, who I had to meet when he was 8 days old. Thankfully, he lives right in Greenville, so we know them very well. But he dove into some fun city cats right away, and then was able to be transitioned to braces. I take no credit for his hair. But this is him on ATA a couple years ago, and then him when he was probably about 2 or 3. And with those braces, you can hardly tell he has no other focus. All right, so let's transition to slightly older toddlers and preschool. So this is a very busy time, orthopedically speaking, and then it's also just a very busy time because we're trying to take what we've gained maybe in infancy and increase range of motion, let's apply it to function now. Babies are not doing much functionally, but toddlers and preschoolers, this is an opportunity for us to really try to transition our focus more to functional activity. And my personal goal, every family is a little bit different, but I'm trying to get any sort of necessary major surgery out of the way. We know these children are bright, they need to be in school and in school on time if we can do that, and we want to try to minimize disruption to their education, if possible. So our themes are for our feet, we're going to be managing any recurrence or residual deformity. For our knees, we're going to push hard to straighten bent knees or extend straight knees. And at the hips, we may be looking at trying to put the hips in socket or doing a reorientation osteotomy if the hip is not pointed in the right direction. Okay, so let's focus in on our feet. For our conservative options, really, we are just spending a lot of time in the brace shop, making sure our braces are fitting really well. We can consider repeat casting or repeat tenotomy versus sometimes after 2 tenotomies, the tendon gets really scarred, and so sometimes instead of just doing it totally blind, I'll make a little incision so that I make sure I get the whole thing. I think it's safer. There's a sensory nervous area that I want to make sure I don't injure if possible. So the DuPont group or Rini and Dr. Nichols' group published on casting for recurrent AMT TEV, and they found that it's effective in temporarily improving passive range of motion, grace tolerance, and delaying or reducing the need for invasive intervention. I think those are all good things, but I think the key word there is temporarily. It's just again, with that recurrent cycle of growth, and with tight and fibrotic muscles, most of these children will experience some sort of recurrence, it's by casting. So let's talk about surgical options. So once they have a little bit older toddler or young preschool child, that's when we try casting, we're not quite getting the results we need. I will then discuss with family like, should we consider like an a la carte soft tissue release, or in a very narrow there's some narrow indications also to maybe do like a tendon transfer too. So we'll go over those two things. So the a la carte soft tissue release, I'm very big on like surgical stitches, so I can't blur it out for you. But basically, we're just taking everything in the back of the ankle, similar to what we do at the knee, and just releasing all of the tight soft tissue structure short of the blood vessel over there. So this is more of a cartoon of what that looks like. So just releasing, again, the tight fibrotic tendons, and then the capsule itself at the back of the ankle tends to be very tight. And usually that opens things up and loosens things so that we can get the foot in a plantigrade position. So results on that, the take-home lesson is about 3/4 of them do require some sort of like reoperation, or recasting, or restent, or restenotomy, but the early, the end result, 95% satisfactory end result. So if, and I think we're talking about a subset of kids that just are failing the casting and stenatomy cycle, and so these are probably harder to treat to begin with. So some things to be aware of is that even despite getting a nice, beautiful result in surgery, you can still experience some recurrence. And then we are removing that blood vessel and that nerve, as we call that, the neurovascular bundle. We're moving that around. And sometimes that can really, even though the child's asleep while we do that, sometimes that when they wake up, they can have some pain with that. Okay, so let's see, tendon transfers. So I think there's pretty limited indications. The foot needs to be flexible, and the tendon has to have what we call excursion, meaning that you can pull on it and actually moves. And so sometimes I have used it as like a quote tether, meaning maybe the muscle doesn't have that much excursion, but maybe I can put it in a more functional location, and it'll help to prevent recurrence. And so this young man had a distal psychomotoric and we did a tendon transfer on him where we took the posterior tibialis tendon, which runs on the back of the ankle, and pulled it through to the top of his ankle. And I think we had a pretty good result. His feet are still not perfect. He can't quite get his feet up, but he still requires braces. But certainly that's better than where he started. So again, limited indications, but I think it's always good for you as individuals with varicocystis that we take care of. Individuals with varicocystis to say like, hey, am I a candidate for this? You might be told no, but it's always worth asking. So, okay, let's transition to school age. So we're just going to kind of keep climbing the ladder. So school age, hopefully we are in a native stage. As I indicated earlier, these are bright kids. I really try hard to minimize their impact on their education and time in school. So really, hopefully we are just on the lookout for recurrence of contractions. Hopefully, if we do see a contraction starting to creep back up on us, we can do, either a brace modification, maybe a short round of casting, or maybe a more minimally invasive surgery to address it. I also embrace it's a concept that we use in our cerebral palsy population, but it's called a single event multi-level surgery, or we'll say SEML. And so, especially if I have a child who maybe was adopted from another country, they're coming to me a little bit later, I try to look at the child, try to look at everything that's going on, and instead of saying, okay, let's just address your feet or just address your knees, like, okay, let's get this child, and take them, everything that's keeping them from being in a functional position, let's address each level, so multi-level surgery. So one big surgery, one big recovery, but then hopefully we're taking a child who's in a very non-functional position and allowing them to with one big procedure, allowing them to have more function. I do think this minimizes the time away from school. I will say, even though this is under the school age, I think this concept, even with our toddlers and preschoolers, that's probably where I'm really more using this concept in slightly younger, age group. Well, I talked about feet, so hopefully again, we're in the maintenance phase, that may look like, continuing with our braces. Sometimes with the older kids, we can, instead of that hard plastic ankle, sometimes we can use, what's called a nighttime pure selection splint, which is a little bit softer and sometimes will tolerate that better. I do have some families that come in just requesting casting, or sometimes I think that's indicated. And I would say it really just depends on the foot. If I feel a foot and I'm like, this is a brick, like it's not moving, then I really just have to be honest that I'm always willing to try, especially if we cast something for our child. But I think I just have to be honest that we may not get as much out of it as we did when the child was younger, just because the bones are now more mature, the joints are not as flexible. So it just might be a longer run for your slide, if you will. So, but then there's about surgical options. So again, I'm just kind of discussing like all surgical options available. I think each child, each situation is unique, and so it's really unfair to say like, oh, you should never do this or never do that, because you just don't know what that child or that family is going through, what their foot actually looks like. So our surgical options is called sclerotony and partial decancellation. So the talus bone, as I was talking to you about before, is that rocker bone in the foot, the ankle rocker bone in the foot. And so it is kind of an older school technique. Sometimes, you can release all of the restrictions in the foot, and there's just simply not enough space. You just can't get the motion that you need. So the thought of taking the talus out creates space in the foot, and then allows you to position the foot where you need it to be, hopefully in a much more functional position. Sometimes taking the talus out usually corrects that recliner component, but sometimes you still have the adductive, remember that V-shaped position of your foot. So sometimes we'll combine this, we'll take the talus bone out and combine it with where you treat the lateral column shortening, where we'll then shift the toes so that it can be pointed more outwards. This is just some pictures of what that would look like. This is just taken from a textbook, so this is not a patient of mine. So a little bit younger foot, but it's a picture, just give you an idea of what that might look like afterwards. And so I do find it a pretty effective operation. Again, this is a 12-year-old, so I'm not really doing this in like 3 and 4-year-olds. It has to be kind of just a very rare indication, but a 12-year-old who has very severe equinus. The back of her heel is almost touching her tibia bone, which those two should be pretty far away. And the foot just really, it was like a brick, like cement moving, like it's just not moving. So we took the talus bone out. As you can see, it's just a lot in a much flatter position, a better position for standing. She was really happy with it. So let's talk about outcomes. I think something to be aware of is there often can be a spontaneous fusion when you take the talus bone out. A spontaneous fusion between the calcaneus, which is your heel bone, and the tibia, which is your shin bone. And to be honest, I don't know if that is a good, bad, or other thing. I would say, a lot of our individuals are very supposed to wear braces, and so when their foot is in a brace, it's not really doing much moving anyway. And so if the heel bone is just it's stuck to the tibia bone, maybe they actually can get out of it because the things are not moving. I think that we don't have enough long-term data to know is that good, bad, or other, but just something for you guys to be aware of. This is supposed to be educational, so you're aware of that. I'd say most of the studies were able to produce a centigrade foot with improved alignment and decreased pain, which then allowed better standing and ambulation. So I think, again, we're trying to remember getting to the point of scale activity. We're dealing with the most severe of severe feet. So this is not indicated for everybody, but of those feet, those patients tended to be satisfied with their procedures. Let's talk about tailored decancellation. Also, kind of an older procedure. There's really not a lot written on it. But this is kind of just, in my mind, it's kind of an in-between. Like maybe I've had kids who already had a posterior release, or their foot just feels really stiff. I'm not really ready to take the whole talus bone out. And man, maybe if we could just make the talus bone a little bit smaller. And so it's kind of in between. And so what you do is you make a incision over the talus bone, make a window inside of it, and then basically scoop the guts of the talus bone out. And it's kind of a controlled fracture, a controlled break of the talus bone. And so I don't know if how that strikes you. Our feet are sensitive, so that might sound like a little bit like, ooh, I don't know about that. But I would say sometimes when you're casting an older child, and the foot is pretty stiff, you're probably creating fractures. We're just not really taking x-rays as you cast. And so this is basically just a controlled fracture in the operating room of the talus bone. So trying to just basically kind of push it down. You can see here, this child went from about 60 degrees of reclining to more time to great foot. The things to be aware of, another example, just of improved alignment. The things to be aware of are the studies are fairly old, but most of them reported 75 to 80% good outcomes. But I'll say, the unknown risk of, is there a long-term risk of arthritis? I think children or individuals with arthritis have an increased risk of arthritis anyway, so, does it increase the risk? I don't know. And then how quickly do these hits recur? It has not been reported in the literature. But I've done a few of these, and I've been pretty satisfied. Stay tuned for longer follow-up for this particular procedure. Okay, so now we're going to wrap up with our skills to mature teens and adults. And so really the theme is like whatever residual deformities we have, if they are bothersome and inhibiting function, correct them. Let's get a foot that is like sounding nice, flat, fits in a brace, hopefully doesn't hurt. And so the start, sometimes we need to modify the individual, modify the child when we do that with surgery or casting or whatnot. Sometimes we can modify the environment. So if we can't get, so what does modifying the environment look like? It looks like maybe we can just modify their shoe or their brace to fit their foot. Why do we need to try to change their foot? Why would we change their shoe or their brace? So that young lady with the very bad congenital vertical talus that I showed you towards the beginning of the presentation, seeing her feet makes my brain hurt because her feet are really bad. But again, we need to put her in some, we molded her feet and then just built a shoe to fit her foot. So it's kind of just bringing the ground to the places of her feet that don't touch the ground. And she's very happy. They're having an Indian fit, so they don't typically wear shoes inside. So we made her two shoes. So she has one shoe for inside and one shoe for outside. And currently she's very happy and doesn't complain of any pain. So I'm going to ride that out until she tells me like feet hurt, and hopefully she continues to do well. So let's talk about surgical options. The external fixator, which many of you are familiar with for knees, we can also use those in our feet. The midfoot osteotomy, arthrodesis, which is the medical fancy way of saying we're fusing the joints. And then let's talk about the dreaded aortic amputation. So an external fixator, this is one in full disclaimer, like I don't really do a lot of external fixators. So the thought is that the frame is just a very powerful tool to where casting is not working, for whatever reason an osteotomy is not indicated, you can put an external fixator frame and very slowly distract and get the foot in a plantar position. A couple studies have shown good results. So there's that. The midfoot osteotomy, I think a lot of children, the deformity that we see is that they really continue to weight bear on the outside part of their foot, that fifth metatarsal. That's usually a really big hot spot for a lot of these kids. If you pull off their shoe, off their brace, there's usually a big callus on the middle of the foot, on the outside part. That's the base of the fifth metatarsal. And I think this midfoot osteotomy works really well for that. So what is it? It's just as described, basically going through the middle of the foot and doing a cut in the foot to be able to then very physically take a foot that's laying on its side and turn it so that it's now in contact with the ground. This young lady, we also did the tibial rotation osteotomy too, which is where that plate screws is. So I think this picture is very telling. This is what's called a pedobarograph. And so it's basically a foot pressure. And so it tells us when a child is walking, where the pressure in the foot is, and so pink is bad. We just want as little pink as possible. So So this is the same patient that I just showed you her x-ray. And you can see that there's a big pink spot under that fifth metatarsal. And it's very obvious to her. So then after surgery, you can see this, her feet are not normal. There's not a normal distribution of pressure. We no longer see any pink, and she's actually happily pain-free. And this is a video of what she looks like. Oops, see if it'll play. Bear with me. There we go. Okay. So the top is before, bottom is after. And I think we all agree this was a much better line after the extra. Okay, let's talk about arthrodesis or fusing. Again, I think a lot of the AMC population is predisposed to having arthritis. So what does arthritis mean? Arthritis is inflammation of a joint or pain in your joint. And some of that is because the joints are so stiff, and so then when they do move, they hurt. So this young man came to us at 16, and he had a lot of pain and inflammation in that ankle, and there really was just not much motion. If you can look close, you can see that the tibia is almost already fused to the talus bone. And so we decided just to formalize that and make to take a little bit of talus, a little bit of tibia out, and let's just make it split in a nice right angle for him to be able to walk on. And I will say once you fuse the joint, then that joint doesn't hurt anymore because now it doesn't move. So there's no so the pain generator is often gone. So that's a video of him walking. I mean, you can only imagine trying to walk on your toes like that all day. That's it has to hurt, it has to be exhausting. And so that's what he looked like afterwards. So let's round out with the dreaded A word, and it's sometimes even hard for me to talk about amputation as a strategy, but I think it is a tool that is a tool of last resort, but sometimes it's the right choice. And that's where nobody can, I feel like we're very good at being inclusive of people of different racial or ethnic or socioeconomic backgrounds, but we also need to be inclusive of people's treatment strategies too, and just recognize that there's conversations that happen within physicians and families that, and there sometimes are reasons for the choices that we make. And so I think occasionally I think that education is a reasonable strategy. So who are we talking about? We're talking about kids that are too fragile to undergo big major surgery, where the deformity is really too severe to be reasonably corrected. A lot of these patients experience a lot of chronic pain before they're just done with surgery, and they want to be done, and they just want a quicker rehab process. So in my mind, if I see that, then I'm like, but what are indicators that they may do well with the amputation? I would really like to see good arms. I did see one young lady at the conference who had undergone amputation, and her arms are not as great, but she has a really good support system. So, either your own simple good arms or a very good support system to help you with putting on and off the prosthetic. And then I also really like to see good hip extensors. So those are the muscles that help to push your hip back. If I see those, then I'm like, okay, I think you would do well with this strategy. And remember, our goal is mobilization. It doesn't have to be walking on our own two God-given feet. It can be walking on a prosthetic foot too. And so let's just use just a couple of cases of that. This young man has both severe feet and severe knees, so he would have to go through an awful lot of surgery to get those knees straight and his feet corrected. So this is not my patient, but chose to undergo a knee disarticulation. And so that's just where he takes the bottom part of the leg off. And I would say he's able to walk pretty well in his prosthetic. His hands are affected, but he has good enough mobility that he was able to on and off his prosthetic himself, which I think is huge. And then I'll end on just one more example of a patient of mine who I recently had. I did not do her surgery, but she just came to me for consultation, and I actually tried to talk him out of amputation, but the child came to me and said, I'm just done. I'm just so done with pain and with surgeries, and I just want this to be my last one. And I was like, can I think I can help you without it? And so I was like, okay, this is, I'm trying to just give her, be able to give her all of the options. So we were able to consult with our prosthetic team and for her to be able to go down and kind of just get a sense of like, what's involved with wearing her prosthetic every day. So I know I have a video with her because she actually couldn't walk barefoot because it was just too painful for her. But this is her just a few weeks post-op, or probably about 8 weeks post-op. Again, I did not do her surgery, but that's what she had called a void amputation. So it's just basically taking the forefoot part off. And so this is her just a few, probably about 6 weeks after surgery. And then this is a quote from her. I was just like, well, what do you think? And she's now probably about 4 or 5 months after surgery. And she says, if you can walk without pain, keep your foot. But if it gets worse and worse and keep you from doing what you love, put it off. It'll be hard, and you get a lot of TV time. But with determination and hard work, you can walk again without pain. Don't get discouraged. And so she continues with her personality on this. She writes music with it. So she really is. She really is. Yeah. So she probably would have done well with surgery because she's got that personality, but yeah, she's just going to be like in her prosthetic.
Squat.
So I really appreciate she is really good. So again, this is kind of just an overview of all of the tools in the toolbox. Each child with arthritis is unique. Each family circumstance is unique. And so therefore, each treatment plan is individualized to that patient and that family. It's really hard to pass judgment of like, well, you have this surgery, I have that surgery. Let's just give everybody the grace to make decisions with their medical teams and their medical providers. I really think though it's important to just keep that holistic view of the patient. Like it's not just the foot, there's a human attached to the foot, and we need to do what's right for that entire human. And so my recommendations are going to get us this. I'll make recommendations, but we make decisions. There's no unilateral, like, this is what we're doing. It's like, okay, this is what I recommend, but what do you think? Like, let's have a conversation around this and together make decisions. And then I also think, like, it's, you know, when we're treating individual babies, like, they don't feel choice in the matter. I mean, my 2 and 3-year-olds, like, this is a conversation with me and the parents. But I think I have a pretty 5-year-old myself. As children get older, we need to teach them autonomy with decision making. It's not that you don't still, like, a 10-year-old can't find their consent, but they get more of a choice in the matter. So that Emily is, she's 11, and, you know, I was just like, I really think we should do more of a reconstruction. She's like, no, take it, you know, so I was never going to get into surgery on her because she said no. And so I really just encourage you guys to just general. Parents, you know, from one parent to another, like, we need to teach our kids from you know, about starting around age 10. Like, this needs to fit with their life and their body, and they need to live with the consequences of the decisions that they take part in. So, sorry, I'm maybe a little bit of a passion there, but we're in this together. It's definitely a journey. We want to do things the right way, the right thing the right way every time, every now. Any questions? We want to say thank you from all of us at Hyer. Thank you all very much. Appreciate it.